Hello, this is Alec Walker, and we're back to discuss the retrospective cohort study by Line Rasmussen and her colleagues looking at the occurrence of diabetes mellitus in persons with and without HIV. I'm going to go through the questions, but I'm not going to give you detailed responses because the highly upvoted questions were really very, very good. So we'll look at the questions, but I'll tell you for the most part some of the thinking behind asking you these questions, and you can return to your colleagues' responses to see the detailed answers. Now, the reason that we asked who is in the HIV cohort is that it's very easy in cohort studies to focus on the defining characteristic that you're most interested in. So here, this was people with HIV. And then set aside all the contextual elements that really tell you something about the population. So we mentioned here birthplace and residence, age, and the health condition, and we saw how those came out of the Danish registries. This is important to interpret what's going on because as we see as the study evolves, that it's not simply a study of people with HIV or people with HIV receiving heart therapy, but it's people with both of those characteristics in a particular place at a particular time. And this is just as important for interpreting the study as the nominal definition of the cohort. In question B, I want you to think about the fact that the entering the cohort requires fulfilling all the cohort entry criteria. And so that, yes, it's the acquisition of HIV if that's on into the study period, but it could well be at the time that you acquire other qualifying characteristics. So that while we think of the cohort as simply HIV and not HIV, people are actually flowing in for a number of reasons. To the extent that time since first infection with HIV is important, not all of these people will be giving you the same answer. So we need to be thinking about this when we go forward to look at person time analyses. The outcome under study was, in principle, it was acquiring diabetes, but of course, in any study, we have to operationalize that outcome. So, really, the outcome was the first dispensing of a medication for diabetes or the first appearance of a diabetes diagnosis in the hospital and clinic data. When we're interpreting the occurrence of diabetes here, then we have to bear in mind that we haven't really studied diabetes. We've studied this particular outcome, and that may be part of the answer to our last question. Cohort membership ends, this is question D, when you fail to meet all the cohort eligibility criteria. Most often, this is the end of some defined follow-up period, but it can also happen when if you have the event out of the event that we're studying, or if there are other things that cause you, for example, to leave the population at risk. We asked that you answer this question for the HIV patients and then for all the comparison cohort patients. Comparison cohort patients were not simply a sample of the general population of Denmark, but they were a group that was selected to match the HIV cohort in terms of the age and sex and the calendar year of entry. And there were four people taken from the general population to match each of the patients in the HIV cohort. This means that the general population cohort is not representative of all Danes. It's Danes with a particular structure of gender and age and time of entry that we saw for the HIV cohort. One way of thinking of this is that we're asking the comparison population to tell us what would have happened to the HIV patients if they hadn't had HIV. Let's go on to the next question, number 8. Here, the highly upvoted answers were all exactly right. One thing that I would point out is that there were some technical issues of some people missing the notation when we have a percentage. The fraction 0.036 corresponds to 3.6%. And we have to be careful not to call that 0.036%. It was clear that people understood what was meant, but for communicating with other people, we need to get that notation correct. In question 9, we were beginning to look at the issue of when can we do a cumulative risk analysis, looking at the amount of diabetes that occurs over 1 year or 10 years or 14 years, versus being forced to do an analysis of person time. And you'll remember that person time is this unit of observation. 1 person year is 1 person observed for a year, but you could also have a person day or a person month. And the power of person time in a cohort analysis is that we can classify person days, months, and years in a way that allows their characteristics to change even within person. So the trick here was to ask which of these characteristics are fixed throughout the study and which change through the course of follow-up. In the rest of question 9, we are looking at the incidence rates as functions of various characteristics in Table 2, and we're looking at at how these vary between one another. And leading into question 10, we notice that the incidence of diabetes seems flat relatively flat, even declining a tiny bit, in the HIV cohort, but it's rising quite dramatically in the comparison group. Now, for question 10, we are looking at why this is the case. So we have several things going on. The time since being in the cohort is, of course, closely related to calendar years, so that people in the later years have been in the cohort for a longer period of time. So they're older. There are things that change with time. It's the general rate of diabetes in the population is rising slightly. And within an aging cohort, you would expect the rate of diabetes to be rising. The authors note that the obesity in Denmark is rising as well. You mentioned all of these issues, and the other possibilities, of course, are that diabetes is being treated earlier or recognized earlier with the passage of time. Remember that we only have an operational definition of the occurrence of diabetes. We don't really know when the diabetes onset occurs. So if people are treated earlier or are given a hospital or clinic diagnosis earlier in the course of developing type 2 diabetes, that would look like a rising incidence rate. I wrote to Dr. Rasmussen when we were putting these materials together to ask what her view was, and let me just read a few excerpts from her message back to me. The comparison cohort is a sample from the background population, but as it is matched on age and gender with that of the HIV-infected population, it is not representative for the entire background population. The majority of the population under study is aging during the observation time, and that is the reason the incidence is likely to be increasing. Furthermore, increasing BMI in the background population possibly plays a role. So that was from Dr. Rasmussen's letter to me. Some of you were skeptical that these issues really did account for all of the change in rates, and I agree with the skeptics. The increase of the size that we've seen in this population over a relatively short period of time is really very large. When we're looking at populations evolving over time, even populations aging like this one, we're accustomed to seeing changes of 20, 30%, but nothing really of this size. The explanations that we have on the table right now may, when we look at things more carefully, account for the increasing incidence. But I would think this should keep in the back. We should keep this in the back of our mind as we look at this paper. So it's a reason for some doubt. It doesn't invalidate the paper, but it's a reason for some doubt. And as we look at further publications from this Danish population, then we'll keep our attention focused. In fact, Dr. Rasmussen concludes her letter to me saying, however, in order to improve the methodology in later studies, the study group, she's referring to herself and her colleagues, would be very interested in a copy of the answers for the assignment. So I will in fact clip out all the most upvoted answers and give her a copy. And we thank you for your assistance in this.